definition of cholinergic system. What is it? Yes? Drugs acting on the parasympathetic system are also called as cholinergic system. So parasympathetic means there is also one more system which is sympathetic system. So sympathetic system, when it is stimulated, yeah, are they flight and flight hormones? Fight and flight. Yes? Yes. So sympathetic system is a fight and flight hormones. And today we are discussing anticholinergic drugs. Something antagonistic to that of parasympathetic system. What is that system? Sympathetic system. So we can find some congruence between the activity of this anticholinergic system and also the sympathetic system. But there are specific differences which can exist there. Okay. So this is in brief to make you feel that it is not a too much newer topic. It's already what you have learned, but in a specific way. Okay. So in brief, what is this autonomic nervous system? The system which is not controlled voluntarily. Okay. So that means there are two systems here, one which can be controlled and one which cannot be controlled. And where our cholinergic system is there, whether it is there in our controlled or uncontrolled, it is there in both. Okay. So cholinergic system is involved in both controlled system, that is autonomic nervous system, and also the uncontrolled system. How it is there, we will be learning it in this class. So central nervous system, we have brain and spinal cord. Peripheral nervous system, we have the located outside the brain and the spinal cord, that is the autonomic and the somatic nervous system. What is the somatic? Motor. So when you want to move somewhere, you want to move your hand, you want to move your legs, you can do that. Which neurotransmitter is involved there? Yes. So CNS, we have this brain and spinal cord, then peripheral nervous system, cranial nervous system, the spinal nerves, sensory, motor. Okay. So in this visceral motor, we have this parasympathetic and the sympathetic region. Otherwise, all the systems is under the control of the voluntary system mediated by acetylcholine. Okay, touch, pain, temperature, proprioception, all these things. So here you can see ANS and the somatic nervous system. Okay, so these are present in the CNS. Okay, sympathetic division is there, parasympathetic division is there. Today we are concentrating on this system, which is parasympathomimetic and the parasympatholytic. So parasympatholytic is the another term for anticholinergic drugs. Okay, so you should not get confused in the exams. Okay, is it parasympatholytic? Is it anticholinergic? You need to put it in your mind correctly. Okay, so anticholinergic system is nothing but the parasympatholytic. Parasympathomimetic drugs are the cholinergic drugs, and that you lies that it becomes anticholinergic or parasympatholytic. So here we can see in the somatic nervous system, acetylcholine is there. Oh, and also there are some fibers which are preganglionic here and some fibers which are postganglionic here. We can make out here one ganglia is there, here also one ganglia is there. So in preganglionic things, what is secreted both in sympathetic and parasympathetic system? Acetylcholine. Okay, so acetylcholine, see how it is there in our body. You need to understand when we are doing something thinking of anticholinergic drugs. Okay, what we are blocking, whether we are blocking both nicotinic receptors and also muscarinic receptor, or else we are blocking only the muscarinic receptors. Okay, so even though we can block this nicotinic or muscarinic or both, can we block this also? Preganglionic release of acetylcholine, preganglionic release of acetylcholine directly to the system, and also in the parasympathetic system. So as it is present something like ubiquitous, most of the actions of acetylcholine can be blocked, but not all the actions. That's why I have just put this diagram to make you understand where our acetylcholine is present. Okay. So you need to understand this. In the exams they will ask this question: what are the preganglionic nerve endings involved in? Which neurotransmitter they release? Okay, even it is sympathetic or parasympathetic, it is always the acetylcholine which is preganglionically released. Okay. So today we are restricting ourselves to this part. Okay, post ganglion and the release of this acetylcholine. It has actions on various systems that we will be learning it in our later slides. So here you can see the parasympathetic system and the sympathetic system. I think you are already familiar with this. Yes? Yes. Okay. So we will start with our parasympathetic system. Okay. So what it does? Constriction of the pupil. Here sympathetic system, dilation of the pupil. What does anticholinergic drug does? They cause dilation of the pupil, but they also have a bad effect that they cause cycloplegia. That means paralysis of those muscles which are causing this constriction. Okay, it is not a direct dilation of the pupil by our anticholinergic system, but here sympathetic system they are causing direct dilation of the pupil. Direct dilation means they are acting on the radial muscles. Okay, so constrictor pupillae, circular muscles, cholinergic nervous system. 3 C's you need to remember. Okay, here constriction of the pupil is brought about by cholinergic system, constrictor pupillae muscles, and they are circularly arranged. Okay, 3 C's are there. Cholinergic system, they are acting on circular muscles and they are causing constriction. If you remember these 3 C's, you can pass over the practical part of this. Constriction and dilation of the pupil, something related to meiotics, something related to mydriatics. All questions you can answer. Only thing is you need to put the right terms in the right place. Okay, so you remember this cholinergic system, and now I am adding one more terminology like direct meiosis, and this is direct mydriasis. But when we use an anticholinergic drug, what happens? We are blocking the circular muscles rather than acting on the radial muscles which can dilate the pupils. Okay, so that is somewhat not direct. So then we call it as indirect dilation of the pupils. And also in the way of dilating these pupils, what they are causing? They are causing paralysis of the circular muscles. Okay, the muscle tone of these circular muscles is lost. That's why we are getting mydriasis. Okay, and something which is long lasting and problematic for the patients also. Okay, so then coming to the next part, that is increased salivation. Okay, here it is decreased salivation. When we use atropine or the prototypic anticholinergic drug, there is decreased salivation. Okay, then there is decreased respiration rate, but here there is increased respiratory rate. So can we use these drugs in patients with asthma? In asthma patient, what has happened? The patient is breathless. Okay, patient is breathless and he is drenched in his own secretions. Here is a drug which can increase the respiratory rate and also decrease the secretions. Okay, so that drug will be helpful in asthmatic conditions. Okay, so then comes to the heart. Okay, heart, there is decreased heart rate by the parasympathetic system, but there is increased heart rate. Okay, when you want to run away from the situation, you see something obnoxious or dangerous, you want to quit that place. So you are getting here increased heart rate. Heart is pumping fast, you are getting more blood, more glucose, you can run away from the scene. Okay, something similar is produced by our anticholinergic drugs also. Okay, at moderate to higher doses they can cause tachycardia, and in conditions where there can be bradycardia, you can use these drugs. Okay, so dilation of the blood vessels, here there is constriction of the blood vessels, but the action here due to anticholinergic drugs varies. Okay, there is cutaneous vasodilatation, and there is also a reaction mediated by the endothelium and nitric oxide release. Okay, here there is some difference. There is some difference in the action on the heart rate also, because at low doses our anticholinergic drugs can cause bradycardia and later tachycardia. Okay, stimulates the GI process. Okay, so here it inhibits the GI process and stimulates the digestive process, inhibits the digestive process. By this process there can be constipation. Okay, constipation, decrease in the absorption. In the similar way, our anticholinergic drugs are also having such effects. Here contracts the bladder musculature and the urination will be increased. Here relaxes the bladder muscles. You need not have urination while you are running. Okay, so those systems should be suppressed. There are similar effects which are produced by our anticholinergic drugs also. Okay, they can relax this muscles. Okay, when this can be helpful, this can be helpful in when the patient is suffering from urinary incontinence or urinary related problems. Okay, that can be helpful there. Okay, so stimulates defecation, inhibits defecation. Some of the derivatives here they can be used for such conditions. So parasympathomimic receptors, they can be both preganglionic and postganglionic. Okay, so with exception of the postganglionic sympathetic fibers to the apocrine glands, most of the glands they have this acetylcholine. So all preganglionic fibers, all somatic motor neurons and postganglionic parasympathetic fibers. Postganglionic sympathetic fibers, they will be having adrenergic system. Okay, so if you get a question like this, where are the parasympathomimic receptors present, then classify anticholinergic drugs like that. You need to remember all these things. Okay, preganglionic fibers, postganglionic fibers of the parasympathetic cell, and also all motor somatic neurons and the postganglionic sympathetic fibers to the apocrine glands. So we got to know that where parasympathetic fibers are present and how they are controlled. About 75% of this, all parasympathetic nerve fibers are in vagus nerve. Okay, so they can supply the thoracic, abdominal organs, heart, lungs, esophagus, stomach. You already saw those organs. It's just a summarization here. Gallbladder, pancreas, upper portion to ureters, all these areas we have this parasympathetic system. So I believe you know where the receptors are present. This parasympathetic system, we can divide them into nicotinic and muscarinic receptors. Okay, so N1 or NM, we have it a neuromuscular junction. N2 or the NN, nicotinic neuronal, we have autonomic ganglia, CNS and adrenal medulla. So the point we need to remember here is our anticholinergic drugs are restricted to the anti-muscarinic effects. Okay, so those drugs which can block or act here, we call them as neuromuscular blockers, and those drugs which can act at this junction like autonomic ganglia, we broadly classify them as ganglion blockers. Okay. M1 CNS, M2 heart, M3 smooth muscles and also in endothelium. M1 is also present in some of the gastric glands. Okay. Here you can see the agonist and the antagonist. I put the slide for the agonist and the antagonist. Okay. So antagonist is the class today we are dealing with. So M1, it is present in the gastric and the CNS, but we are concentrating on the gastric glands and the treatment for the hyperacidity here. The drugs are pyrazipine and olanzapine. Okay. In the cardiac muscles, we have this antagonist at M2 receptors. We have tropicamide and the agonist is methacholine. M3 receptors, we have this tolterodine and dariphenazine. We commonly use them in urinary related problems. You need to remember there is a vascular endothelial receptor in the M3 where that will be put into application while we are studying about this cardiac effects of atropine. So classification of the drugs, what are the drugs we have? Okay, it is not a exhaustive classification. We have good few drugs in each of them. There may be some other drugs also. Okay, so natural alkaloids we have atropine, spasmolytic and a mydriatic agent, but less commonly used for its mydriatic effect. Okay, hyoscine we have this, also called as scopolamine, most commonly used for motion sickness. Semi-synthetic derivatives of them, that is mydriatics. Fometropine we use in using the ophthalmic examination, and also for the fundoscopy we use the fometropine and tropicamide. Why? Because atropine topically has very long action, whereas for systemic action the action lasts for 4 to 6 hours. Okay, so that's why we have this semi-synthetic derivatives which are shorter acting and serve our purpose. GI spasmolytics we have hyoscine butyl bromide. Synthetic compounds we have GI spasmolytic, that is oxyphenonium. Anti-ulcer drugs, that is pyrazipine and olanzapine. They act by blocking the M1 blocker which are present in the GI mucosa and helping in the gastric acid secretion. Okay, so by preventing the gastrin release and also by decreasing the gastric acid secretion, these drugs can prevent the gastric ulcers. So anti-asthmatics we just discussed, it can decrease the secretions and also cause bronchodilation. So for this purpose we have these drugs, that is ipratropium bromide and tiotropium bromide, which are given by inhalational route. Okay. So urinary system we have this antispasmodics such as flavoxylate, oxybutynin and trospium. Anti-Parkinsonism drugs. Yes, Parkinsonism is caused by deficiency of dopamine. But why we are using this anticholinergic drugs here? You need to remember the dopamine and the acetylcholine, they are delicately balanced in the CNS. Okay, so when the dopamine levels have decreased, what can happen? Action of acetylcholine will be more. Okay, so rigidity, tremors, all these things associated with Parkinsonism, those symptoms due to cholinergic overactivity can be increased. Okay, so one way is to increase the dopamine and bring it to the level of the acetylcholine. Another way is increasing the acetylcholine also. Okay, so here we are having this anti-Parkinsonism drugs. Okay, that is central cholinergic. By acting on this, by using these drugs, we can prevent the rigidity and tremors associated with that system. And we use them in drug-induced Parkinsonism. Drug-induced Parkinsonism, when can we get this? Yes? That's very good. Why schizophrenia? What are the drugs used for this conditions? Antipsychotic drugs. The drugs used to treat schizophrenia can cause Parkinsonism. He is right, but why? Okay, so what are the drugs used for schizophrenia? Do you remember some drugs? They act on which system? They act on dopaminergic system and they increase the dopamine levels. Okay. Excuse me. So the drugs which can increase the dopamine levels, what they can do? Is it so? Yeah? They decrease the dopamine. So once they decrease the dopamine, what can happen? There can be decrease in the areas where required, and there can also be decrease where the areas it is not required. Decrease is not required. There is a normal functioning of dopamine and it is needed for its regular action. If dopamine levels are decreased, what can happen? Parkinsonism. Where dopamine levels are increased, schizophrenia. Okay, so this is a treatment associated with the treatment related disorders where we have to save the patient, but we need to think of the side effects. If the patient is suffering with Parkinsonism, usually they are age related disorders, and we need to think that after some time the patient may develop schizophrenia, and a patient has already developed schizo in his middle age, and we are using the drugs which can increase the dopamine level. What can happen? The patient will land up in Parkinsonism. So these are the treatment ironies we need to adjust with. So these are the drugs: benztropine, piperidine, trihexyphenidyl. All these are drugs which are used in drug-induced Parkinsonism. So what are these anticholinergic agents? Today we are dealing with the anti-muscarinic agents rather than the anticholinergic agents. Why it is more muscarinic, anti-muscarinic? Because we are not blocking the nicotinic receptors. Okay, that's why it is more of anti-muscarinic agents. That too, we are blocking the M1, M2 and M3 concentrate. So these are the agents which block the muscarinic receptors and inhibit the muscarinic function, and they are useful in clinical situations where we need to curb this cholinergic action. Okay, they have no action on the skeletal neuromuscular junctions where NM receptors are present and autonomic areas where ANS receptors are present. We'll come to the slide. Have you seen this slide in the practicals? That slide you might have seen. Okay, I am coming to that slide later. So atropine is the prototype of this group. Okay, you already got to know some of the actions of this group. Okay, what they can cause and all. So here you can see this is the cholinergic synthesis of acetylcholine, then acetylation, then extrusion into the neuromuscular junctions where it comes and acts on this post ganglionic neurofibers and brings about its action. So atropine is a belladonna alkaloid, okay, and has high affinity for muscarinic receptors. It is a competitive inhibitor. Remember, it is a competitive inhibitor. That means its action can be bypassed by increasing the acetylcholine levels. It is then preventing the acetylcholine from binding to its site. Atropine is also obtained from Atropa belladonna. Do you remember some story about this belladonna? What is belladonna? Have you heard of it? Yeah? Belladonna, what is it? Yeah? I'm not. Okay, okay. You are telling like some ladies they used to put it in the eyes. Why? Mydriasis. What if mydriasis? So what? So they used to think that this mydriasis can make them more attractive. When the pupils are dilated, they felt that they become more attractive and they were using it. So belladonna in it is actual literal meaning is beautiful lady, like that. Okay, so they used to use it in history. It is like that, but here in practical, what will happen? If we use that atropine drops on the eyes, what can happen? They used to apply it on the eyes or they used to consume it? Yeah? Actually they used to consume it, because if they would have applied it on the eyes, what could have happened? You know that it can cause mydriasis and cycloplegia, and it can last for minimum of 4 to 7 days. So they would have rather become blind. Okay, so because mydriasis, in mydriasis they can only see the long sightedness will be there. The short sightedness part will be lost because the pupils need to constrict and decrease the light coming inside the eyes. Okay, so they used to consume this atropine plant products so that their eyes become, their pupils become dilated. So a belladonna alkaloid has the high affinity. Here I need to show you some of the drugs which can block this acetylcholine synthesis. These are the important questions which the examiners might be asking. What is this? Hemicolium. Here you can see a drug there, hemicolium. Okay, hemicolium is a drug which can have negative effect on the choline synthesis. Okay, so it is trying to prevent the binding of this choline with CoA and form acetylcholine. Okay, the first step is blocked by the hemicholine, and this vesicular incorporation. It is a vesicle containing acetylcholine, and this vesicular incorporation is blocked by vesomicol. Okay, so hemicholine, vesomicol, and we also have this botulinum toxins. Okay, botulinum toxin can prevent the release of this acetylcholine, and finally we have this atropine which can block the which can competitively inhibit the action of the acetylcholine. Okay, hemicolium which is blocking the acetylcholine formation, vesomicol blocking the vesicular incorporation of this acetylcholine, and then we have this botulinum toxin which can prevent the release of this acetylcholine. Okay, have you heard of this botulinum toxin? Where? How do we acquire this? Disease. Food poison. Then you know it was one of the important weapon for biological warfare also. Okay, so the Spanish people used to use it. They used to try this one. So atropine action in CNS. Okay, so overall we can tell the whole picture of this acetylcholine atropine on this CNS as mad as hatters. Okay, there's some people at low doses it has some stimulant action, some depressive action. Finally, if there is adequate or moderate to high dose, the person will be out of his regular consciousness. How it is possible? We will see it here. Okay. So atropine has overall stimulation action, and its action is not appreciable at low doses. When we are giving it like orally, there will be lesser CNS penetration. Okay, and it produces this peripheral effect because of restricted entry into the brain. Okay, so at higher doses or moderate doses, what it can cause? It can act on this vagal, respiratory and vasomotor centers. Okay, so by blocking the relative cholinergic overactivity in the basal ganglia, it can suppress this rigidity and tremorism Parkinsonism. That is one advantage part. But in high doses, what can happen? There is cortical excitation, restlessness, disorientation, hallucination and delirium. Okay, so have you heard of organophosphorus poisoning? So what is the primary drug we are using? Main drug for treatment of organophosphorus poisoning, which drug? Atropine. Okay, so atropine, when we are giving to such patients, we have to see the signs of the toxicity of this atropine, because we are directly giving intravenously every 10 minutes up to 2 grams. So we need to see the signs of toxicity. Here is how there will be. First point is there is mydriasis. Then we also have this cortical excitation, restlessness, disorientation, hallucination and delirium. So when I was doing my house surgeonship about 10 years back, we had a patient with organophosphorus poisoning. We had him treated. We have put him on atropine intravenous going on. Suddenly what happened? Somehow we have, there was no one at particular moment. He has reached the highest concentration or the toxic dose. Then the person has become hallucinated and he went to the top of the building, jumped from the top of this building. So because of the drug or overdose of the drug, what had happened? The person